I had a question about the pharmacological interventions. I carry some orlistat around, it's OTC, just in case I happen to, have to take in some oil when I eat somewhere. But usually I don't have much fat in my diet, so I wouldn't be wanting to use that regularly. But of the other four that you mentioned, if there are no contraindications, do you have a preference on one of them, or how would you decide which one to go with?
Yeah, good question. And so orlistat, I don't use typically a lot because, like you said, you have to be on a high fat diet for it to work. And for people who don't know, it sort of makes you have a bunch of loose stools. So it's not often sort of a thing that's really desired by most of my patients. So people are wanting to have nice, normal form stools, not a bunch of loose sort of stools throughout the day. So the other medications, it was a recent study that sort of was able to show us and sort of help us use phenotypes to figure out which one that patients would work best with. And so it all depends on sort of the patient's sort of trajectory, what they've done before, their contraindications, family history, and some of those, because if you have certain family histories, you're not a candidate for some of those medications. But in general, if it's a patient that is sort of significantly hungry all the time, that sort of has a hard time feeling satiated, a hard time getting full, then the Cousimia, which is the phentermine and topiramate, is a good option for those patients. For patients that have sort of nighttime eating and grazing and sort of binge eating and sort of snacking and emotional eating, I use Contrave in those patients. And then for patients that may have diabetes, but also sort of feels maybe have diabetes and also sort of I can sense such as something hormonal happening that say they're already sort of having a sort of pretty well controlled diet and portion size they're working out, but they still can't move those things. It makes us think that something hormonal is happening. And so Wegovy may be a good option in those people. So, and is even beyond that, it still depends on, like I said, family history, blood pressure, side effects of medications matter too. For example, with phentermine, people it causes insomnia. So if I have a patient that already has insomnia, that is not a good option. If it's a patient, it also can cause sort of tingling in the fingers a bit. It goes away, but it can happen. And so if I have a person who is a hand surgeon and needs to have precision, then that medication, even if you want it, it's not a good go for you because you have to do very fine movements. So it's all, sort of a little bit of this and a little bit of that before you sort of make a decision.
Thanks again, Doctor. And up next, we're going to bring in Mike. Mike, you're welcome.
Hello. Dr. Lassiter, you are such a firecracker and a knowledgeable person, and I hope that I wouldn't have to pay by the word that you give us because you really put the words together in your description. My question is, I'm trying to be preventative on leaky gut. My wheat zoomer was moderate for leaky gut indices. So I take apples, I eat apples for the pectin. Any other suggestions besides that to kind of make sure I don't get a leaky gut and the symptoms that come with it?
Yeah. So thank you, first of all, for watching all of my crazy for an hour and a half. You guys are troopers. The fellows can only last an hour, so this is impressive. But so leaky gut is not sort of a technical sort of diagnosis we have in GI. So, but what we alluded to a little bit earlier is sort of what actually happens is sort of breaking down that membrane, that one cell thick membrane that we have in the small bowel that creates sort of in a sense where the term came from, sort of little breaks in the barrier, right? That's what causes the symptoms that people typically will present to us with. And so to overcome that one particular food that I tell patients they should start to incorporate, but it's really sort of general and overall. And sort of when I get patients off of processed foods to sort of pay attention to those food labels when they're noticing, most of my patients will say, oh my God, now that I look in my cabinet, everything in here has emulsifiers and additives in it. I'm like, yeah, I know. I went down that rabbit hole years ago. That's what sort of got me understanding what was happening to my patients in the first place. And so that is sort of the first step, is getting patients off of processed foods. And just the thing that sort of heals that microbiome and sort of creates sort of that diversity and sort of that sort of counteracts sort of you having that inflammatory process is sort of having that high fiber diet, having sort of that diversity of fruits and vegetables. So apples are great, sort of getting a variety though. So getting sort of changing it up and getting many fruits and vegetables throughout the day, having whole grains, having a diet that is high in fiber. Most people worry about protein, but most people in this country are definitely not deficient in protein, but they are deficient in fiber. So a lot of people are constipated and everybody's bloated and has sort of nausea, vomiting, and usually it's because of their lack of fiber intake. So when I get patients to sort of get on fiber, actually drink water, get rid of those processed foods, it's hard to notice, man, I have more energy. The fogginess is gone. I'm not having the bloating. I'm actually pooping every day. This is amazing. And I feel like I completely empty. I'm not having to sit there forever and strain. It's sort of a natural process. And that's the goal. It's what we want. And so that's the sort of the longer answer to your question is sort of not having to focus on one particular food, because we know just having one food over and over again doesn't give you a diverse microbiome, which is the goal. But it's really sort of switching up those colors, making things sort of look beautiful when you eat. And so how I make my salads at home is I'm like, I don't have any purple here. Let me throw some purple cabbage. I'm missing some orange. Okay, I need some carrots or a yellow bell pepper. And so making things colorful and pleasing to the eye, because from a nerdy perspective, what I know you're getting is more antioxidants. You're getting plenty of vitamin C, vitamin K. You're getting, your calcium, magnesium. You're getting all of these things by just having this prettier plate with a bunch of colors. So for me, it's the nerd piece, and I'm enriching your microbiome, but also you're getting all those micronutrients. So you don't need all of these multivitamins and things that people are taking, because you're getting in the form of actual food.
Around here, we don't think it's nerdy at all. We think it's really cool. Just saying. Thank you so much. And up next, we have Steve. Hey, Steve.
Hi, Ben. Thank you. Doc, young man, 36 years old, moved back home because of the pandemic, lost a lot of weight originally, went to True North, a lot of successes. Now everybody around them tells him, oh, you did so great. And the weight is creeping back up. Probably regained 15 pounds, maybe more so far. At what point are these drugs indicated? Because his general practitioner says, oh, no, you're doing so great. Keep it up.
Yeah. And so common, very, very common. And so I go back to that very first slide and just remembering that it is a chronic disease. It is relapsing, meaning it comes back no matter how long, when people say once an addict, always an addict, and there is always a process. Same thing with food. And sort of recognizing that that thing will come back around. And so I like to use medications on my patients, sort of hit a plateau, and especially if they're starting to get a gain, but also trying to figure out what happened. I can usually pinpoint and find a thing that has occurred that sort of helped to sort of get them to that point. Sort of why did they get there? Was it a new medication? Did they start moving less? Did they start to feel more hungry? Because ghrelin level goes up and makes you more hungry when you lose weight. Did they start sort of getting a little bit more processed foods? Was it the fact that they were super, super restrictive, which is how they lost the weight, and now it's sort of that was hard to maintain? Is it that we need to change sort of the ratios of their plate a little bit more? Do I need to sort of increase to them having more fiber on the plate, so more servings of fruits and vegetables, and reduce servings of sort of that like beans, or just like a smaller amount, so just a fourth of that plate? Do we need to sort of revisit those things to sort of refresh your memory? Because you get out of habit sometimes. And I'll have patients that sort of are eating a healthy diet. They're eating a lot of that healthy diet. And like cultural, we talked about, for example, one of my patients is from where is she from? The PR, Puerto Rico. And sort of their culture was that they ate a lot of beans, a lot of legumes. It's great, right? But how much of those beans were we eating? And so she was eating like 2 cups. In addition to her grains and all this other stuff. And so all we did is things that she already liked. We just changed it to where most of her plates were salad. And she was having beans. Yes, I want you to have beans. That's great. That's feeding your microbiome. It's a lot of fiber. It's plant-based protein. I love it. But we're going to change it to a fourth of your plate. We're going to change it to an actual serving, which is a half a cup, which she thought her grandmother lost it. It was like, oh my God, that's not enough beans. Are you crazy? But changing that ratio was able to help her eat the foods that she enjoyed, still be able to have those bonds with family, but just really reducing those amounts, and started to help with that weight loss. So I think it's sort of thinking about why did that start? So what changed over that period of time when they started to regain? And then sort of, being able to make those changes and sort of institute sort of meds as you need, for sure.
Thanks very much for that, doctor. At the moment, I don't have any other hands raised. We have a few more minutes. I have some questions for you, if that's okay.
All right.
And if anybody else does have a question, hit your reactions. Well, it looks like Steve has a quick follow-up. Let's jump right in there. Hang on. Hi, Steve.
Yeah, he rejoined the workforce, and now there's a break room with lots of coffee, which he wasn't doing. And you know, you have coffee, there's loads of donuts, and comes home and dad says, "What'd you do?" "Nothing." Now there's a history. Dad used to have this and has other motivating factors that sort of keeps me on the straight and narrow, but he doesn't have these health issues. He's a young guy. And I know there's a donut and there's a cupcake and there's, you know, just enjoy life, Dad. Come on. And oh boy. Thank you.
Exactly. I knew it's always something, right? And so what I do in those patients is I try to give patients, because 30, like I tell my patients, you're 30 years old, you're 35 years old, to say that you're never going to have a chip again or never have a cupcake or a cookie again is setting yourself up for failure. It's going to happen, right? So my goal is to transition you to sort of some of those healthier versions of those snacks. And so don't cringe, but like I give people recipes for chickpea chocolate chip cookies that are super easy to make, so they're sort of guilt-free, they taste amazing. If I'm able to fool my godchildren, then I can fool anyone. These kids are way too honest, so they will certainly tell you if it's terrible. But it's sort of showing people those ways to sort of be able to have those snacks, so you don't feel like you're being deprived. So you don't do it every single day. So for those in the hospital, it's like the worst place ever, because the nurse's station will always be chunked full of cookies and cupcakes and chocolate, and the nurses are, "Come on, doc, how don't you have this with us?" Right? And so that's always going to be there. So I tell patients, you know, we have to figure out ways around that, right? And so having your snacks that you bring into work with you, that you keep, that are kind of stacked there. I give people sort of these cauliflower chips that they love, it's avocado oil chips. So you have those snacks. So if you feel the need that you sort of want or you need those, then you have it available, right? And so to make things super easy, my patients who love brownies, there's a sweet potato brownie, a black bean brownie. And so I tell them just to get over the idea that it's made out of black beans, because you won't know it once it's done. But giving people these other options so they feel like they're in control too. So you have to be able to not feel like you're being deprived, which is what I am completely trying to avoid in my patients. And feeling like you're able to have some of those good things. And what people start to notice is they actually they will notice over time that they start eating sort of things that are not so sugary and not made with processed stuff, that those other things sort of taste way too sweet when you go back to them. And so you don't even like them anymore. I have patients that say, "Man, I used to love these particular cookies, and now they just taste, I can't even eat one because it's so sweet." And that's the goal, to get your body, you're changing your microbiome from the nerdy perspective. I'm changing your microbiome so that you do not crave those things anymore. So you've changed the bugs that are in your gut. So you no longer have created that environment that craves those sort of things. So you don't want them anymore. When I was a resident overnight, one of the things that we would do, because we were sort of poor residents and there's nothing around, you ate graham crackers and peanut butter and Cokes from the nurse's stations, from what the patient stashed, because that's what you had to keep you up at night. The idea of that now is like, I don't know how I did it, but it was sort of a survival mechanism. Again, we talk about that nighttime eating too. But those are things that you sort of, once you change your microbiome, you don't crave. And so it's slowly getting him to sort of change his habit, the behavioral piece a little bit, to sort of bring in sort of his own thing and keep his little snack pack at work of sort of those minimally processed. Simple Meals is actually a really good brand that if you look at the side, they don't have a bunch of that processing stuff that you see in, a Chip Ahoy or Oreos. So that's another option I use for my people.
Thank you so much. My wife's a pediatrician, and when she was in residency, she went through the same thing. She lived on Diet Coke for 2 years and all these horrible things that they had just to try to stay awake for 30-hour shifts. I know they don't even do that anymore, but
30 hours. My mom was like, "How do you do a 30-hour shift? There's only 24 a day." I'm like, exactly. So imagine.
Yeah, exactly. And the truth is, of course, that the hospital's got all of this food that they should not be serving their patients or their staff. It's horrible. We have probably less than a minute left, and I'm just curious. You mentioned that a lot of times somebody will go through changes, and then they're even if they've lost weight, now they're heading back in the wrong direction again. Obviously, so many people talk about that it really stems from something emotional. And again, I understand that that's not exactly your specialty. Do you ever team up with folks that handle that sort of thing to work together in your programs?
Yep. We do a lot of referring to local therapists, but most recently we just partnering to sort of build in sort of weekly therapy sessions for our patients to do group therapy, because they all have the same sort of complaints and problems, but they all think they're alone and they're the only one. So they beat themselves up because it must just be me. And so I'm always saying, no, 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 it's not just you. This is everyone. This is a common thing. And so, yeah, so now we have we do monthly meditation too, because none of us sit still enough to breathe. And so my idea is to get people to really embrace sort of those blue zones, which includes meditation, includes mental health, includes sleeping. So people were like, oh my God, really? Are you really going to start with sleeping and drinking water? Like, come on, where's the hard stuff? Like, that is the hard part, to get you to sit down and breathe and actually feel that breath come in and out, to slow your heart rate. So yeah, it's definitely, we just recently have been able to, I refer them, but then I realized that people wouldn't go, but now if it's with me and here, then they're like, oh crap, she's going to know if I don't do it. So they actually do it now.